Welcome to all of you. Happy 2026. And I'm hoping that this year will be very productive for each and every one of us. I really appreciate your time and I'm excited about your future RPSGTs here. Looking forward to having at least 10 to 20 RPSGTs this year. And I'm hoping you will be on that list. If you're taking a test, you're going to be sitting down and going to be asked questions after questions. So what we're trying to do over the course of many weeks, if not a few months, is to get desensitized, to get used to that. By the time you actually sit there taking the actual test, you would have already reduced your anxiety about taking the test, sitting down, being questioned. And what I felt was missing for a few months is the actual identification, seeing something and then identifying it. So this is what we're going to try to do today. Some of the questions are very simple and some of them will require some explanation and some will not. This is only going to be a 25 question identification. I'm going to show something, a diagram or whatnot, and then we're going to try to answer. So if you can't answer with your voice, you can answer on the chat. I just want your participation. And there's no judgment. You can be correct 100%. You can be wrong. It's okay. When you make a mistake, it's something that you will correct. All right, let me share my screen and then we'll see. So it's not about just right or wrong. It's about getting used to this. All right, so let's identify some things here. What are you looking at right now?
Brainwaves?
Yes, correct, brainwaves. So this is a sleep stage. Anybody want to try? What is this in particular?
Is it 3?
Very good. This is N3. So slow wave or delta sleep, which is N3. So again, the first one is, this is obviously delta sleep, but big waveforms. And anybody remember what is the minimum voltage or microvolts for delta activity?
75.
Very good. 75 microvolts. How about this? When you're looking at your epoch and then you see something like this, what are we identifying here?
Snore.
Yes, very good. You got your snore. Do you notice anything else? What else can you tell me about the screen? Because to me, it looks weird.
The EEG po.
The EEG looks like it's referenced to only one reference, or it looks very identical. So I don't agree with this. To me, this EEG looks odd. And there's also EKG artifacts. You see this EKG?
Yeah.
How it's aligned with the spikes? Okay, so this is also EKG artifact. So if you see it on exam and the pointer is pointing towards this, the EEG, it's trying to ask you what artifact it is. So this is an EKG or ECG artifact. But if it points here, of course, this is a snore. And if it points to the respiration, what do you think is this? What, is respiration supposed to look like this? Anybody? It's weird. Is this normal?
Yeah, it's misplaced.
It's misplaced? Or
Yeah.
anybody else? Have any? Feel free to just butt in and discuss. This is a flow limited breath. It's supposed to look like this. Look at the thermistor. This is actually, if you look here on the left, this is pressure. So it's the nasal cannula, the pressure transducer or the PTAF. The next one over is the thermistor. So for thermistor, it monitors the flow pattern, but through the air, the temperature of the air that goes in and out. That's why it's a therm, because it's based on temperature. Cold air goes in, hot air or warm air goes out. But if you look at the pressure transducer or the pressure, it looks odd. This is because this patient is having some form of airway collapse. Okay, so this is a flow limited breath. Okay, so there's a few kinds of flow limited breaths. There's an M shape, which is like this. Do you see how it looks like an M? So
Yes.
there's an M shape, there's a flattening where the tip or the peak of the flow pattern is flat. You will see like a sinusoidal like this, and then all of a sudden it becomes flat on the top. That's flattening. And there's also what they call a reverse chair. It will look like a chair, but it's like the seat here, and then it goes like this, but this will become flat first, and then there's a peak. So it looks like a chair. There's a few things that now, when you're looking at a sleep study, you're not just seeing flow patterns. You can now identify flow limitation. Why is flow limitation important? What do you think?
Determine sir if there is hypopnea.
Yes. So possible hypopnea, there could be an impending airway collapse. Because if there's already flow limitation, that means there's already some form of collapse, but not completely yet. There's some form of collapse at the back of the throat. So you might expect some apneas later on. Okay, very good. This is a difficult one. I can tell you that. What do you notice? What are these in the box? And what are these outside the box? At least I gave you a clue here. This is vertex, but it's quite odd. I wonder why. Feel free to answer. Feel free to ask a question. Feel free to comment. Okay? So any guesses or any answers? So let me ask you a question. Do you think that this is an adult or a pediatric patient? This is a pedia.
The waves are big.
Yes, the waveforms are so big. Okay, that gives you already a clue. When you see patterns like this, so many delta activities, but yet it's not purely delta. It's not purely slow wave. You see some smaller patterns and then big patterns. So this is a slow wave. This is delta activity. But how come you have some slow, low amplitude mixed frequency here? And then the clue here, it says this is vertex. This vertex is ginormous. So it tells you that this can't be an adult. This is a pediatric. In fact, this is possibly an infant patient, correct? So the answer here is where it's pointing into is, like I said, is this side, unless you are a pediatric. It's slip spindles for a pedia, especially infant patient. For infant, you have to get used to and pass all these big waveforms. And there's two types also of slip spindles. And there's synchronous and there's asynchronous. Meaning to say, synchronous, you can see it on both sides of the hemisphere. You can see it on the left side, you can see it on the right side. All of the EEGs that's labeled with an odd even number, F4, C4, O2, all of that are even numbers. That's on the right side. But on the left side, you have your F3, C3, and O1. So if you're recording both sides and the spindles are the same and it happens at the same time, it's a synchronous spindle. Not that we need to know that, or do we need to know why? We just identify. But it's good to understand, because if we're the techs working that night and you're able to create your notes even more detailed, it gives the doctors a lot more information to consider. If you just put their spindles, you won't be wrong. You're correct. But if you put asynchronous spindle, that gives the doctor an even better understanding of what he or she might do. Having a synchronous pattern, he or she might be able to dig into this patient even more thoroughly. Does that make sense? Next, this is a pattern. I made it big, but they look like fingers. They look like little fingers. What is this activity?
Windows.
Close.
Alpha.
Because sleep spindles, hertz or frequency is really close to alpha. It goes from 11 to 14 or 12 to 16, while alpha is 8 to 13 hertz. So they overlap. The difference is that spindles occur in burst, okay? It will just be a snip, like half a second, okay? And it will be spread out. The point here is it might look like spindles, but if it lasts longer than a second or two or whatnot, it's continuous, it's an alpha activity. Now, I don't want to make this more difficult, but in addition to this, can you see alpha in REM or only in wake and N1? Yes, correct. Very good. So what you do is, for example, if this was 1 second, right? Since we're already here, let's say, can you see the lines here? So let's say this is 1 second. Let's see how many activities we have. 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9 wave patterns within 1 second, which means this is 9 hertz. Got it? So if this is 9 hertz, it is within alpha frequency, because alpha frequency again is what?
8 to 13 hertz.
8 to 13.
Yes, 8 to 13 hertz. So since this is 9 hertz, then this is an alpha frequency. Like what Hawa said, it could show up in REM if your wake frequency is 9 hertz. This can show up in REM, and how you can determine is if this same alpha activity frequency is 1 to 2 hertz slower. Okay? So if you're looking at the eye, but then you see some alpha, so you're confused. Just go and look closer and count the activities. Okay, this is 1, 2, 3. If it shows up at 6 or 7 hertz, okay, that's close enough to alpha, but it's slower than the normal wake alpha frequency of the same patient. So it is REM, okay? Now, some activities, you don't count this as 2, okay? Because some might count this as 2 activities, but it's peak to peak. So this is where it starts, it begins, and then this is just a polyphasic activity, right? It's just polyphasic, but it's not 2 activities, it's just 1. So it dips there, then it ends here. So from here to here. Next, when you're looking at EEG, you're going to look at the epoch at 10-second epoch. So you actually get it closer. You will see things bigger. But when you're doing sleep, you're going to push back a little bit. It will become 30 seconds. And so this is how you're going to be looking at the alpha. So you can see all the way here, you have alpha until it stops here. So what do you call this activity past the alpha?
Is it sleep onset?
Yes. Correct. This is sleep onset. Very good. So when you see alpha attenuate, so this is, when you look at alpha, you're also looking at the occipital channel. So O1, O2. Even though you see alpha on the central region, you're not going to base your alpha from the central region. You're going to base your alpha in the occipital channels. So you look at O1 and O2, all of a sudden it becomes, wait a minute, it disappeared. It attenuated. So this is now the beginning of your theta activity. Got it? So this is now the sleep onset. So if this was labeled as epoch 2 or 3 or 4, whatever the epoch is, that is the epoch that the patient actually started switch to N1, okay, or sleep onset. So this is crucial. On what particular study is this? PSG, titration, MSLT? Yes, it is crucial in all studies, but it's even more important when you are doing an MSLT, because in MSLT, you have to be precise as to if the patient falls asleep or not. In PSG, you're counting so many events and you're looking into a 6 to 7 hour study or even 8. But in an MSLT, you have a very brief opportunity to identify whether the patient went to sleep or not. You only have how many minutes? 20.
That's
yes,
correct.
You do 20-minute naps. Let me pause for a minute. How are we doing? Any questions? Now, let's identify this, which we already did, right? What's the term for this?
LAMF.
Yes. So you can identify it as theta waves, or the other terms is LVMF, low voltage mixed frequency, LVMF, or what's the other one?
Low
It's LAMF, low amplitude mixed frequency. So low amplitude mixed frequency is typically your activities, and you can see it in what sleep stages? N1, N2, how about N3? How about in REM?
REM.
So theta, or low amplitude mixed frequency, can be seen in N1, N2, N3, and REM. Because remember, let's say for instance, I think you're referring back to N3. So I get it. Let's say here, let's say you are in N3, right? And you see nothing. Oh, even better right here. Sorry about here. This is N3, correct? However, N3 doesn't have to be 100% delta activity. What is the rule for N3 identification?
It's 20%.
Yes, at least 20.
Seconds.
6 seconds.
Yes, at least 20% only. When you see 20%, which is 6 seconds, right? If this is an epoch, so what is 20% of 30 seconds? 6 seconds. So let's say here is 1 second. 1, 2, 3, 4, 5, 6. If this is all the delta that you see just here, and the rest of this is, what do you think? If this was all low amplitude mixed frequency, isn't this still delta or N3?
Correct. It's still 3.
Yes. So when you take the exam, make sure that you don't just call N3 when you see so many delta. You really just need to see at least 20% or 6 seconds worth of delta activity, because they don't have to be clumped in one area. They could be spread out. And what channel do you usually look at, delta?
Frontal.
Yes, going to be on your F3, F4. So theta waves going back is 4 to 7.99 hertz. How about this? When you see this in your PSG, what are we looking at here?
Muscle artifact.
Yes. Anybody else? What do you think is this? You said multiple artifacts. You could have bruxism and it can look like this because you see different artifacts. Muscle artifacts here, electrode pop. When you see this become flat like this, like a normal, like this is a ruler, this is a line, that means the artifact went beyond the scope of the sensor. It becomes flat, okay? But this is a lot of muscle activity right here. There's an electrode pop. This is electrode pop. And so there's movement, there's muscle here and electrode pop. I don't see 60 hertz artifact, but then again, we're going to be going over those artifacts when we do that class. So this is an arousal as well. The patient could be bruxism, grinding teeth, but there is a definite pattern for bruxism, which I can show you later. Movement artifact and muscle artifact. All right, very good. Now, what are we looking at here? Okay, what are we looking at here? It says, you can see the days. You have days here, Tuesday, Wednesday, day 1, day 2, Saturday. Then you have some activities, all right? And this is kind of odd. Like, how come here you don't have many activities here? So what are we looking at? Anybody want to take a stab?
Is it a hypnogram?
Histogram.
Very good, thank you. This is a hypnogram, but this is particularly a download from what type of device? This is all activities. That's a hint for you. Activities.
Actigraphy.
Very good. So this is a download from an Actigraphy, an Actigraph. Okay. What they do is, when you give the patient a sleep diary, you will give them the device, and the device usually looks like a watch, and they'll wear that for 2 weeks straight. They'll wear that for 2 weeks straight. They can take it off during the day, or it's better if they keep it on, because what they do is you'll give them that sleep log or sleep diary, and they'll write there Monday, Tuesday, Wednesday, what time did I go to bed? From 10 p.m. to 3 a.m. And then you will now read that log and compare it to the download. So if I'm the one looking at this download, I can see that the patient said they went to bed at this time. So I will tag this as the patient's sleep time from here. And then the patient says in the diary, they wake up at 5. Let's say this is 5 a.m. So I'll tag it. Okay. So now it highlights that portion of the time that the patient said they went to bed, not necessarily sleep. Okay. And on Wednesday, the same thing. The patient said, I went to bed a little bit later because the day before I went to bed at 8. The next day I went to bed at 10. The next day I went to bed at midnight. The day after that I went to bed at 2 a.m. The day after that I went to bed at 3 a.m. So when you do that, you highlight the time that based on the sleep log, and then you compare it to the actual Actigraph download. When you see this, immediately you can say that, wait a minute, the first night that the patient went to bed to sleep at 8 p.m. or so, the patient was really not asleep, was it? If this is during the day or during when the patient is moving about, etc., and then they went to bed, all of a sudden there's a little bit of activity here, quite a lot. And you can assume that maybe this patient went to the bathroom, okay, and then went back to sleep. Then they actually fell asleep. And then they woke up because they have a lot of activities here from this time to this time. And then later in their sleep, they went to sleep again, but have some activities. So looking at this with limited amount of information, this could possibly be apneas or leg movement because there's some form of activities. Remember, this is only actigraphy, okay? And now the patient said, I woke up at, say, 5 a.m. All right. And then you can tell that it's true because then the patient was already having a lot more activities throughout the day. And the following night, a patient went to bed later, fell asleep immediately, and then for some reason they woke up. They have some activities. Maybe they were just tossing and turning here. And usually pretty much the same time as the night before. Can you see that? Yes? And then,
Yes.
okay, and then the patient continues to sleep but have some form of activities. All right? So these activities, again, might be snoring, it could be moving their legs, could be bruxing, something that the actigraphy is picking up. Okay? And then the following night, the patient really went a little bit later, maybe a couple hours later, didn't sleep immediately, and then went to sleep almost the entire night except with some activities. So you might say this patient might have some form of either apnea, snoring, leg movement, bruxism, or whatnot. Every time the patient goes to sleep, it's not a quiet sleep. It's not completely quiet. There's always some form of a little activity. Then when the patient wakes up, it's later that night, that day. So now that you see the pattern, will you agree with me that this patient does not have a good sleep hygiene? Or do you think this patient has good sleep hygiene? What do you think? So if you have a good sleep hygiene, you should be sleeping habitually at the same time. And if you have a good sleep hygiene, you should also wake up or get out of bed at the same time every day. Okay? Now, I say this because you can quickly see if you have a graph of 2 weeks worth of data, you can immediately tell if the patient has good sleep habits or bad without even looking yet as to whether they have snoring, apnea, do they have leg movement, etc. You can already say that this patient, no wonder this patient has insomnia because they don't have good sleep hygiene. They go to bed at different hours throughout the night, and throughout the morning, they wake up also at different hours of the day. Any question on this? Let me ask you a question again. Who has done actigraphy studies here? So the doctors are the only one that will touch it. But at least now you know what they're looking at. This is primarily given to what? Insomnia, OSA, what kind of patients?
Insomnia.
Yes, you give this to insomnia patients. Technically, insomnia patients, they don't need to be in a sleep lab to do an overnight sleep study because first they need to get fixed with their insomnia unless they have OSA. So it depends now on whether the doctor assesses this patient as an insomnia patient or as an OSA patient. The doctor, when the doctor sees this patient under initial assessment or appointment, the doctor will ask questions. Maybe the doctor will give this patient an Epworth Sleepiness Scale, a stop bang, or an ISI, which is a questionnaire similar to stop bang, but it's for insomnia. Okay? So if the doctor deems, wait a minute, this patient has negative risk factors for OSA. So the stop bang questionnaire is 0, nothing positive for OSA, then the doctor will not waste this patient's time to send them to an overnight sleep study. Otherwise, that's a waste of time. If the patient does not have OSA but is very sleepy, very symptomatic, they'll look into insomnia. Maybe this patient has insomnia or a possible EDS, excessive daytime sleepiness, or possible narcolepsy. When the patients have that, the doctor can opt to give this patient a 2-week diary and then with an actigraphy. So when the patient comes back 2 weeks later, they'll be seen by the doctor. The doctor will read this report and say, you have a bad sleep hygiene. I'm going to treat you with your sleep hygiene first, and then we'll also see if you are going to require any CBTI. What's CBTI?
Cognitive behavior therapy.
Cognitive behavioral therapy, CBTI, and usually you'll have with medications or without medications, okay, either or. Now, the answer is actigraphy download. Next, what do you think is this? So here you see it's a report. You see the patient's info, and you see an indicator for apneas. In the analysis, there's an AHI, HI, total sleep time. What do you think is this report? Sorry, it's overstretched and a little blurry.
Is that a sleep study result?
Correct. So this is a sleep study result. However, it's not a comprehensive sleep study. This is a home sleep test result. So typically home sleep test results, the ones that are flow-based, what are the flow-based HST studies? You have your Apnea Link, you have your Somfit Pro, you have your Night One from Philips. All of these home sleep testing devices are small, but they also have a cannula to monitor their flow pattern, or even a thermistor, so that the doctor is able to see if they stop breathing or not. But this is a home sleep testing device report. And you know that for a fact because usually they won't have all the other parameters, particularly the leg movement, periodic limb movements. Arrhythmias they can show, but not all home sleep testing are cleared yet for arrhythmias. But you can see their pulse, you can see their flow pattern, you can see their snoring, and some can identify central versus obstructive sleep apnea. So the report for home sleep testing is minimal. However, it's not going to be like that for too long because the newer devices, the newer home sleep testing devices, are now able to identify sleep stages. So you will see now N1, N2, N3 RAM, or they can justify whether it's RAM versus non-RAM. So they can also then identify arousals, because if you can identify EEG pattern, you are able to identify arousals. Now, what are we looking at here?
Central sleep apnea.
Respiratory events.
Central apnea, very good. What else? Crescendo decrescendo pattern, which is what? This is a Cheyne-Stokes pattern, and this is definitely a central apnea. What else?
An artifact.
Very good. What kind of artifact?
Ballistic.
Cardio-ballistic. I don't know why they term ballistic. It's not respiration. So this little pattern here usually will follow the pulse or the patient's heartbeat. So there really is no pattern. It's central apnea. But how come you see this squiggly lines, but then there's completely no effort? There's no effort. This patient is not breathing because this patient's having Cheyne-Stokes because of the crescendo going up and then decrescendo. So crescendo, decrescendo pattern followed by a flat line. So if this lasts for a few cycles, then this is a Cheyne-Stokes respiration. Very good observation. And what is the other thing that usually accompanies a Cheyne-Stokes respiration pattern?
The saturation.
The cyclical or cyclical pattern of oxygen desaturation and saturation. So if you look at this, it goes up and down, just like a seesaw, it goes up and down pattern. It follows exactly a Cheyne-Stokes respiration pattern. This gives you another confirmation that this is in fact a Cheyne-Stokes respiration pattern because of that saturation. Going up and down looks like a sinusoidal waveform. All right, very good. Now, since you already mentioned the Cheyne-Stokes respiration, we'll skip this one. All right, and what are we looking at? This is too easy.
REM.
So this is REM, okay? But my next question will be, what is this? Anybody want to take a stab on what is this sleep stage? Very good. So this is tonic REM, right? Look at the chin, very high muscle tone. So this is REM without atonia, meaning there's muscle tone. And usually when you have tonic REM, you don't have many, what is this?
Eye
Eye
movement.
movement.
Yes, you don't have many eye movements. So what is this type of REM?
Phasic.
Very good. This is phasic REM. All right. So you have phasic REM right here and then a tonic REM. So the main difference is muscle tone, very little muscle tone. And so we have to remember that fact. Okay. When we talk about REM, we usually say REM. I know it's REM because there's no muscle tone. Not all the time. Okay. So just to be clear, when you see eye movement and then there's no muscle tone, that's phasic REM. But if you see very little eye movement and then there's an increased muscle tone, but yet it's very quiet. See, this is all low amplitude mixed frequency. Very difficult. The only thing is that when you get used to scoring, you're going to be very sensitive in little fluctuations like this. This gives me an idea. This is REM right here. As soon as I see this pattern. But the other pattern that I look at really is the respiration. Okay. When you're scoring and you're reading a sleep study and you're not sure, especially during tonic REM, that you don't see the clear eye pattern in phase and out of phase, then I look at the respiration because the respiration will become typically erratic, right? They will have varying tidal volume, varying flow, amplitude. The signal will be big, small, very small, then big again. It's very erratic. So that's how you know that the patient is in REM. Any questions? What are we looking at?
Hypnogram.
Very good. Absolutely. So this
S
is
kasi sir eh. SS3.
you know why? Because this is an old slide. You know how we used to call sleep stages before? It used to be stage 1, stage 2, stage 3, and stage 4. Does anybody know or remember the difference between stage 3 and stage 4? Before it became N1, N2, N3, and then REM. No more stage 3 and stage 4. So historically speaking, we used to follow not the SM guideline. We used to follow the R and K manual. So it's Rakshafen and Kale, or however you pronounce it. But the R and K manual is based on those two doctors creating the manual for staging. Okay. And when they did that, it lasted until about a few decades, until 2006 when AASM first published the very first manual for scoring. So it became SM, but before that it was R and K. The manual, we used to call it S1, S2, S3, and S4. S3 is when it's 20 to 50% deep sleep, delta waves. But then if you have more than 50% delta, then you will call that S4. All right, but you don't need to know that anymore because that's not going to show up in the test. All right. So when you're looking at this hypnogram, can you tell me anything about this hypnogram? Do you think this was a very quiet sleep or normal sleep? Or is this an interrupted sleep?
I think it's very good sleep, sir, since there's a 5 cycle of REM.
1, 2, 3. Broken, but yeah, 1, 2. This is broken a little bit here. So let's just say
Yes, sir.
1, 2, 3, 4, and 5. Very good. So that's probably a pretty long recording. So from 0 hours to 8 hours. So the patient was in bed for 8 hours. Sheesh. I wish I could be in bed like that long. And also, good point that the patient had very minimal arousals. So the wake here is around here, very short time here. If you put this together, this is still very short. What do you call that term? Where you gather all the wake. Very good. Wake after sleep onset. WASO. We count that from lights out to lights on. Any awakening or wake patterns within the lights out to lights on is part of the WASO, which is counted in what? Percentage, minutes? Minutes. So you count, what's your WASO? You say, oh, it was 10 minutes. Oh, okay. So that's not bad because this patient slept for 8 hours and was only really awake 10 minutes. That's not too bad at all. Meaning to say, if the sleep was very high and very low WASO, this also correlates that the patient had a good sleep quality, also very good sleep efficiency. We'll discuss more of that later. All right, what is this?
Hypopnea.
All right, very good. Anybody else have any answers? There's an arousal
Yeah,
there.
arousal.
So version 3, you don't need any more descent unless. So there's an exception here. Anybody know? There's an exception here. Without the desaturation, this will not be accepted by Medicare. That's the catch, okay? They need 4%. All right. I know it's a lot, but my goal here is to repeat things until it becomes natural for everybody. And for some of you, this is probably a redundant things already. All right. Identify. What is this? Couplet. This is a couplet. First of all, this is a PVC, premature ventricular contraction. So there's an isolated PVC here. So the arrow is only pointing to the couplet. So when you're asked in the examinations and there's an arrow pointing to something, don't look at other stuff. What are we looking at? Okay, I hear mixed. Anybody else? Good answer. This is a mixed apnea. Okay, so why? Because it starts off with a central apnea. So you might confuse this as effort, but it's not. It's just cardioballistic. You got it? It's cardioballistic. If you look at the interval of the EKG, it's following the interval of the artifact. So you know for a fact that this is flat. Okay, this is just cardioballistic artifact. So this is not a real activity. This is just a central apnea. But then right around here, this part right here on the abdominal channel, the patient starts to breathe. This is no longer a central. However, there's still no flow. So since the obstruction continued, this is now an obstructive apnea. Here, there's no flow, there's no effort, so it's central. But here, at this point, you have effort. So once you have effort, and you can see the paradoxical activity, meaning to say, it went in phase and out of phase, right? The thoracic and abdominal channels went in phase, out of phase. They are paradoxical, right? Against each other and towards each other. That's paradoxical breathing. Over here, before the event, they are synchronized. Breathing patterns, however, here, they are paradoxical, which is another indication or signature of an obstructive apnea. All right, so this altogether, you call a mixed apnea. You do not need 10 seconds worth of central. You just need 10 seconds minimum of the whole event. Any questions?
If you encounter a mixed apnea, you still increase.
Because you still have an obstructive component.
Okay.
That's a good question. Very good. Anybody have any questions? Anybody? So this is the old RERA, but now it's a hypopnea. There's the clue right there. This is definitely Hypopnea. Before, it used to be RERA because there's no sign of desaturation, which I didn't include. But the whole point here is just to get used to when you see something that's not sinusoidal, because not all patients will have sinusoidal beautiful patterns. You'll be dealing with flow patterns that are just obnoxiously ugly waveforms. But when you see some things like flattening or a mixture of, it might look like a chair. This one looks like a chair because it's worse than a typical flattening flow limitation. Okay. So when you have sinusoidal breathing pattern, that means the airway is open. And then once you start to have some airway collapse, maybe there's the back of the throat, maybe on the soft palate or the uvula or the adenoids are starting to relax or the tongue is starting to fall backwards and start to limit that flow, then it starts to show a different morphology or different shape of the flow pattern. Now, when you're going into your lab and you see a pattern that's like this, understand immediately that these are already flow limited breaths. And typically some of these patients, if you see this and they're still awake, that means they're pretty bad on the, what scale is that when you ask the patient to open up their mouth and they go, what is that called? Starts with an M. Malampati, Mallampati. So usually ENT doctors that are also sleep boarded, they always look at that. And also some doctors who have surgical background, they always look at that. Not all labs will ask you to do a Malampati, but usually when they do, the doctors are also there. They'll come in and assess the patient and then they'll put it's one page typically. They'll identify whether this patient is 1, 2, 3, or 4. 4 being no, you won't have any opening at all. So when you have patients that they go and you can't even see the back of their throat, you just see their tongue, then that patient is pretty severe. Patient's already having blockage even before they actually fall asleep. All right, so RERA is now hypopnea. Now, sometimes you'll see flow patterns and they go way beyond the normal flow pattern, or when they do recover, but then they go beyond. And what is this typically when you see this flow pattern? They go way beyond the baseline. So the baseline is here. You have an imaginary baseline. Why do you think is that? What is this feature typically on PAP devices that will allow for this to happen?
EPR, or pressure relief.
Very good. EPR is one. Okay. So anybody else? EPR, what else? So it could be EPR, it could be also C-Flex, because when you say EPR, that's ResMed. C-Flex is Philips. Then they also have things soft PAP with Fisher and Paykel. And so you have to look for that pressure relief or pressure release. It's when the CPAP is giving a pressure, and when the patient exhales, it drops the pressure slightly. And typically you have a setting of 1, 2, or 3 settings to drop the pressure, to allow the patient to exhale out a little bit more comfortably. All right. And what is this? Don't tell me it's an Apple Watch. Could be. Has the name there too. I should have covered the name because I'm not marketing for these companies. What is this? This is a
Wearable watch, of course.
Okay, good. So I hear some home sleep studies, wearable watch, but this is an example of an actigraphy. Okay, so most actigraphy, in fact, right now the most common actigraphies are your watches, the smart watches, right? You have Apple, Samsung, Amazfit, all that. All of these devices now, on the phone, it's on the watches, it's even on the rings. There are some that are only bands, and they're all for actigraphy. But this is the report that we saw earlier. This is pretty much the source of that report. It can show patients' activities throughout the day and night. So if the patient wears this for 2 weeks, you'll be able to identify whether the patient has a good sleep hygiene, whether the patient has a regular sleep pattern. In a sense, those patients that are exhibiting some form of insomnia, they might have irregular circadian rhythm pattern. They might have delayed phase syndrome or early phase syndrome. It helps a lot just understanding the download and the sleep log for not the non-OSA patients. However, even when I mention non-OSA, some patients actually have a combination of both. They will have insomnia and they will also have OSA. What is that called? What are patients called, or what diagnosis is given to patients when they have both insomnia and OSA? COMISA, right? Complex insomnia, there's a very small prevalence out of the obstructive patients, but they do exist. Some of these patients, they will present first with obstructive apnea, and so they will be treated with PAP therapy. So once they are on PAP therapy, eventually they start to again not do well on PAP because then they can't sleep. What usually happens is when they present first with obstructive apnea symptoms, they're sleepy and they snore, they stop breathing. So now they get into treatment. Once they get into treatment, the obstructive sleep apnea slowly goes away or is reduced to normal values. Then what happens next is the insomnia surfaces. So when that happens, these patients will require both. They will keep their PAP therapy, but they'll also start their CBTI. They can be placed on medications and be given behavioral changes or behavioral modifications to improve their insomnia. They can be given additional medications or not. All right, there's a few more questions. What am I looking at here? What are we looking at here? This is first AT. However, there is a pattern. So now it's not just a PVC. This is every other abnormality. When it's every other abnormality, then this is a bigeminy. When the abnormality is every third pattern, then that's a trigeminy. When it's every fourth abnormality, then that's a quadrigeminy. Okay, but earlier we identified two PVCs together. They was one after another, so that's a couplet. When you have three PVCs together, it's a triplet. But that's already enough to call a triplet a what? A VTAC, ventricular tachycardia. You only need three. All right, moving forward. What am I pointing at here? Or what is this study pointing at? It looks like the study is crunched. Leg movements, particularly what? So this is what?
Right.
Is this a PLMS?
PLMS.
Yeah. It's correct that it's leg movements. Maybe it's just one or two. But now we can see that this epoch is not 30 seconds. This is more than 30 seconds. So if you have an epoch that's 120 or 90, and then you have multiple leg movements, then you only need how many leg movements to consider it as a PLMS?
4.
You need 4 leg movements to consider it as a PLMS. Within how long?
90 seconds.
90 seconds. Very good. So within 90 seconds, if you have at least minimum 4. This one you have 1, 2, 3, 4, 5, 6. Why didn't I count separately, the left and the right? Why did I just count it as 1? Because they happen at the same time. They have to have space in between. Okay, but we're not going to get into PLM, so I don't want to confuse you. Just remember that if you have multiple leg activities, leg movements while asleep, within 90 seconds, and it's at least 4 leg movements, it's a PLMS. All right. What am I looking at here? What is this questionnaire? Stop, bang. Very obvious with the STOP highlighted. Do you snore? Is for the S. Do you feel tired, right? For the T portion. Has anyone observed you stop breathing or choking? I hope nobody is choking you but is just observing you, right? And do you have high blood pressure? So this is for hypertension. And the reason why too is that any patients or anybody, even people that you know, your friends, your colleagues, or yourself, if you have hypertension and you're placed on hypertensive medications and still your hypertension pursues or perseveres, that means you are more than likely at least 85% or higher positive for sleep apnea, right? There's many clinical evidence that shows a difference of between 70 to 85% positive for sleep apnea, that there's a high correlation between drug-resistant hypertensive patients to OSA. Body mass index, of course, the higher the BMI, the more likely the patient will have OSA or higher risk for OSA. Then anybody who is older than 50 years old, more than likely have higher risk for OSA, particularly if they have 17 inches or 43 centimeters or larger. I had a discussion the other day with one of the students because he said, Ken, you said 40 centimeters. That's not 17 inches. I said, oh, wait a minute. And I look back. I think I did mention 40 cm. I should have been more precise. And the reason being is that it just I just mentioned it because here in the US, do we count in centimeters? We don't. We always count in inches. But he's right, because if the student is from outside of the US, they will be measuring, and I should have been more precise. So anyway, for female, 16 inches or 41 cm. And lastly, if the patient is male, they have higher risk for OSA. Do we give this questionnaire to insomnia patients as well? We don't. Okay. But if the doctor says, oh, maybe this patient have COMISA, and then, yeah, why not? But yeah, if the patient has zero risk factors for OSA, they don't need this questionnaire. It could be used as a screener, and then you don't need to keep it. All right, stop bang for OSA patients. And now, what am I looking at here? Where is my arrow pointing at? So if I do this, what is that? I'm not giving you any multiple choice answers. So it's harder than arousal. Very good. So this is an arousal. And because you have increased muscle tone on the chin, then you have increased muscle tone in the EEG itself. Typically, when you highlight an arousal, it's on the central area. You highlight here. You will click and drag, at least if it's 3 seconds in non-REM, then it's an arousal. But why is this patient having an arousal?
Respiratory event.
Yes. So what is this kind of event? The best answer is OSA. This is an obstructive apnea. If you count here, yes, you might still have a flow. But if you highlight this all the way here, and you don't have to have 100% cessation of breathing. What's the definition for apnea? You have to have at least how many percent?
90%.
Yes, 90% reduction in flow. You can still have some flow, but it's just 10% remaining or less. This is an obstructive apnea, okay? The only weird thing here is there's no paradoxical movement. This is not paradoxical. It's still synchronized. So it's kind of odd, but yes, this is obstructive apnea. There's effort and then there's no flow. And then the patient also, another thing to consider here is this. What is this? You look back on the left, it's from the snore channel. So this is what kind of arousal? Snore arousals. How many types of arousals do you have? You have snore arousals, you have respiratory arousals, you have movement arousal, and you have spontaneous arousals. Very good. Well, another thing that I noticed on this is, see, the saturation looks more of an abrupt incline. It's cyclical, but it's not. So it still tells me it's obstructive event. But the pattern here looks like a crescendo. Doesn't it look like crescendo, the crescendo? Right here. Anyway, the obstructive event is more clear on the thermistor. All right. How about here? What are we looking at? What kind of study is this? My question was, I show you this picture. And now my question is, what type of study is this?
Titration.
Very good. Titration or treatment study. And the reason being is because you see the pressure here. And now it's confusing because what kind of titration is this? It's confusing because this is from a Philips G3. This is a G3, but it's
Ay,
not.
CPAP pa rin.
Yes, it's not a bi-level
CPAP pa rin, sorry.
titration. Yeah, no, it's okay because the EPAP and IPAP are shown instead of having CPAP. It shows EPAP and IPAP. So you'll think immediately, oh, that's bi-level because you have two pressures. But if you look at the pressure, it's the same all the way down. That means there's no difference in inspiratory or expiratory, which means it's a CPAP titration. Very good. Obviously here, there's still obstructive events. So there's still an arousal. There's a snore arousal also, but you can definitely see there's an obstructive apnea. You can probably get away if you just point this as hypopnea, but it depends on how long this is. But it looks like very long. It looks like an obstructive event. All right, so titration study. And now let's identify this. What is this, first of all? You answered me earlier that when you see this is a hypnogram. But what type of hypnogram is this?
Split.
All right, very good. It's a split night hypnogram. And the main reason is what?
In the first glance, you can see there's a lot of desaturation during especially in 10 to 11. However, when it comes to 1 a.m., desaturation is being resolved. Maybe because of the CPAP titration is begin.
Yes, so very good observation. And typically, when you do a split night, you need how many hours of sleep recording? You need 2 hours. So this is perfect because whoever the tech was split this patient around after 2 hours. So you can see this is the saturation. So it's a pretty bad desaturation, meaning there's a lot of apneic events here. And so you can see it by the desaturation all the way down to the low 70s, if not even high 60s right here, if we kind of guesstimate. However, after 2 hours, around past midnight, close to maybe 12:30-ish or so, there's a stop in the recording. So this is when the tech came in, probably tested the CPAP, when the patient is fitted correctly. So now the patient fell asleep immediately. And so look at the improvement in desaturation. This is a pretty radical improvement, won't you say? So it's not almost, the patient is like in the 90s. However, from 1 a.m. and around 2, the patient starts to desaturate. Why is that?
Patient is on REM.
Very good. The patient went to REM. Here, it seems like after 2 hours, the patient went into REM, which is correct because what is the REM cycle? It's every 90 to 120 minutes. Yes. So every 90 minutes to 120 minutes, which is 2 hours, we expect people to be in REM. This patient went into REM, ended up with some events, and so then it got better again. Okay, so meaning to say, if we look down here, we can see exactly the whole story. The patient was awake very short and then went into N1 and N2, N1, N2, N1, N2, sometimes wake. So it's very severe, very bad sleep architecture because there's so many events. After 2 hours of recording, finally, patient was awake for a few minutes while the CPAP's being applied, then went to sleep around here, close to 1 a.m. Then the patient went immediately, almost just a few minutes later, was in deep sleep. You see that? So a patient is now recovering. Deep sleep is for recovery for adults, if this was an adult patient. Woke up a little bit and then went back to sleep. And then a few minutes later went into REM now. All right. So after REM, a little bit of arousal, back to REM again. A little bit of arousal, back to a long REM. So this is definitely REM rebound, like what Jayat is saying. And then eventually, almost 2 hours of rebound. That's pretty good. Typically, our first cycle of REM is just a few seconds, not even a few minutes. But this patient went almost, 2 hours and some change in REM with very little interruption because of the CPAP. The tech was able to titrate this patient really well. And then the patient went back into a little bit of awake period, then went back to sleep. And majority of the time, the patient was in deep sleep. Okay, again, recovering. And so by the end, before the end of the recording, the patient was still experiencing more REM. So in essence, this one pager right here gives you a lot of information, gives you the whole story. So if you were the physician or the nurse practitioner or the physician assistant looking at this patient, just with one look at this hypnogram, it tells you hypnogram and histogram. It tells you the story of what happened to this patient, whether this patient was successfully titrated, whether this patient was severe, whether the tech titrated the patient really well. And I think, is this a successful titration? I think the tech did really well. All right, so folks, that was the end of this review. And do we have any questions? I appreciate your patience and appreciate your participation. So if there's no questions, I would like to give you back your time, and I hope you either enjoy your day, you get some rest. All right.